Good evening. My name is Ken Haggerty, and I have the honor of starting off this evening's proceedings. I represent the Dolan Lecture Committee. It's made up of Dr. Don Nolan, Dr. Larry Gatos, and Bob Ryan, and myself, and Dr. Dolan. You'll notice in the program it's listed as the steering committee. We discovered a couple of years ago that nobody steers Dolan, so we call it the lecture committee. Those of you who know Dr. Dolan will appreciate that. I would like particularly to welcome the Dolan family. Miss Christine Dolan, Mary Ann Dolan Stoddard, and Alexandra Stoddard, welcome. Carol and John Dolan, and Jeff Dolan. Jeff's husband, as you may know, is off fooling around the state doing something that he can't be here tonight. But we think he's probably in an airplane between Lynchburg and East Outhouse, Virginia somewhere. But his thoughts are with you, Bill, on this evening. This whole thing started a number of years ago. As you know, this is the sixth event we've had. And this time of the year, we think of the All-Stars being selected for baseball. And I must say that we've had the All-Stars of Medicine to come here to speak at this lecture series. And it does great honor to Dr. Dolan, who has dedicated his life to medicine, to patients, to medical education, and mostly to this institution. So when you have all-stars like Tony Fauci and Denton Cooley and William Roberts and George Lundberg and Gianni Bonadano came from overseas, and now Dr. Gerald Mandel, we are really very honored, Bill, and you should feel very proud of what this means to the community. My part of the program is just about ended. I threw away my half-hour speech, but this evening's offering demonstrates the serendipity of the choice. I've already told you about our past speakers, and Dr. Mandel continues this tradition of excellence. My pleasure to introduce Jim Reeder, our hospital chief executive officer and president, and he brings us greetings.
Well, thank you, Ken, and welcome everybody. It is an honor for me, excuse me, to also welcome the members of Bill's family, as well as all of you to this 6th annual Dolan Lecture. It's especially gratifying for me to see so many practitioners here tonight. In addition to our desire to recognize Bill Dolan's continuing contributions to our community and our hospital, it is a great relief to spend an evening listening to and learning about the real substance of patient care rather than the reimbursement and other kinds of topics that are filtering out of the White House and Capitol Hill these days. I can take some time off from reading these enormous documents that land on my desk from every consulting firm in the country. You don't need to go buy them for $45 off the back of a truck like they're selling them. You can just sit around here and they'll just slowly arrive in the mail. It's wonderful. I'm also gratified to see the members of your entire clan out here tonight, of course with the exception of Bill, who's flying around the state, as was earlier said. This lecture and the history of its establishment are representative of the best of the Arlington Hospital. The cooperative effort of the clinicians here on staff, and especially Don Nolan, Director of Medical Education, along with board members, with many of our donors who created this lecture endowment, demonstrate the active spirit required to maintain the vitality of our healthcare institutions. It is this ability to work together for the greater good that will bring us through the challenging future that lies ahead. Again, it is an honor for me to welcome you all and to thank you for your continuing support of our efforts to provide the best in patient care for our community. And now, without any further delay, I would like to ask the president of our medical staff, Dr. Chuck Lefton, to come on up here and introduce our lecture for this evening. Chuck.
Thank you, Jim. As all of you know, it's been the tradition of the Dolan Lecture Series to invite people of preeminence in their field to this lectern. Today's lecture is certainly no exception. Dr. Gerald Mandel, through absolutely no fault of his own, was born in New York City. Except for a 2-year hiatus in the public health service, he spent 15 years in the Cornell University system. It's my understanding he has big red tattooed right here on his arm. He was an undergraduate, a medical student, a house officer, a fellow, and finally an instructor in the Department of Medicine. In 1969, he left New York City in search of civilization and arrived here in the Commonwealth of Virginia and moved to the University of Virginia faculty. Since 1970, he's been the head of the Division of Infectious Disease in the Department of Medicine there. And in 1981, Dr. Mandel was named the Owen R. Cheatham Professor of the Sciences. If the size and weight of one's curriculum vitae is a measure of success, then Dr. Mandel's CV is of hernia-provoking proportions. He has published over 100 articles, has made innumerable textbook contributions, and his textbook, Principles and Practice of Infectious Diseases, is a standard in American medicine. It was that text for which he received the Association of American Publishers R.R. Hawkins Award for the most outstanding professional and scholarly book in 1979. If being a prolific publisher isn't enough, Dr. Mandel's films of phagocytic activity have been recognized and lauded worldwide. Dr. Mandel is committed to medical education as evidenced by his presence here today, by his contribution to shaping the medical education process at the University of Virginia. He is a sought-after guest lecturer, has been a visiting professor at Yale University, the University of Melbourne in Australia, the University of Oregon, University of Texas, my alma mater, the University of Michigan, of course, his alma mater, Cornell University, and the Albert Einstein College of Medicine. Dr. Mandel is on the editorial board of the Medical Letter and is the infectious disease editor for the Cecil textbook in the Yearbook of Medicine. He presently serves as the president of the Infectious Diseases Society of America. It must be patently apparent that Dr. Mandel plays a pivotal role in the research and treatment of infectious diseases. I'm anxious to hear about his topic, new infections, so please join me in welcoming Dr. Gerald Mandel.
Well, I'm delighted to be here, and I thank you for the invitation. It's a real honor to be able to honor Dr. Dolan and his family on this occasion. I've gotten interested in dogs and dog breeding, and I see that the genes of public service and good for mankind carried down. I don't know the stories on the rest of your kids, but I'm sure they do you proud too. So this is a special privilege to be able to honor you at this occasion. The other introductory comment I can make relates to the wonderful presentations that the young residents and medical students that are working at the Arlington Hospital gave in stumping me with cases. I didn't know what they had, but the cases were beautifully presented and well understood. And I think those of you who haven't met these young students and residents should, because they are the cream of American medicine, and you should be proud that you've attracted them to your hospital. Infectious diseases is an interesting specialty. I'm suffering presently from an infectious disease. That's why the water is here, and I hope my voice will carry me through the rest of the talk. But I guess I should be glad I'm not a specialist in sexually transmitted diseases, because I don't have one of those, but I do have a respiratory disease, which I'm sure I picked up in New Orleans at our last infectious disease meeting. If I can have the first slide. I guess the screen needs to come down and stuff. Oh, do we show it on that, or do we show it on the white screen? White screen. Okay, so this will be a dramatic rendering of Mr. Jefferson's lawn. And I'm sure that all of you have visited Charlottesville. I've run into a number of Charlottesville friends here. But as you know, Mr. Jefferson's University is very special to us. And of course, we always have to tell people that it's not the campus, but it's the grounds. And it's not the quadrangle, but it's the lawn. But it's a wonderful place to be. And again, if you haven't been down to Charlottesville in the last few years, you should see our brand new University Hospital, which is now about 2.5 years old, which is really very beautiful. The rule was that the University Hospital could not be taller than the rotunda. And luckily, it's downhill, so they were able to get 8 stories on the hospital. But the young architects and engineers that heard this rule sort of, said, well, and they built a tower on top of the hospital for cooling and utilities. And the university board said, chop it off. And they did. And so the top of the hospital is truncated to make it lower than the top of the rotunda. Let's see if these buttons work. Forward doesn't seem to work. Okay. Infectious diseases are still with us, and there's been a lot of publicity recently because of outbreaks of interesting infections, and we'll talk about some of these. The concept of new infections is not a new concept, but it's something I want to reinforce. And the definition of new has to be a broad definition to include newly recognized diseases, not just newly appeared diseases. This doesn't seem to be doing anything. Let me see if I try. Oh, maybe 1 is the right. All right, let's see how that works. There was one of the new infections is depicted here, and of course you know what this is. And it's interesting that the medicine men out on the Navajo reservation, when the first cases of this strange respiratory virus disease appeared, said, we know what it's due to. And they said it was due to the heavy rains that occurred in the corners of the Navajo reservation where the four southwestern states meet. And these rains resulted in a very heavy crop of piñon pine nuts, also known as Indian nuts, and an increase in the rodent population, also known as deer mice. No, neither of these works, so I guess you'll have to... Oh, all right, my instructions were to use this. Should I try this? All right, let's try this. Thank you. The background of the hantavirus infections is shown here. Certainly we knew about hantavirus infections before, and it's a genus of the larger family, the Bunyaviridae, which is a group that includes California encephalitis and, more appropriately, the hemorrhagic fever viruses. And there's a Hantan River in Korea, and actually several thousand U.S. troops got sick with this during the Korean War. So this is Hantan virus is one of the group of hantaviruses, and you see I've listed some of the hantaviruses, which include the Hantan virus and another one that's obviously Korean, the Seoul virus. And these cause chronic infections in rodents, and humans become infected by infectious aerosols from rodent excreta. The usual disease that was known before this recent outbreak is hemorrhagic fever, where the patients get petechiae fever and die of sepsis in a small percentage of cases, usually about 5 to 10% fatality. And this was what was known before. But now we see a disease where the patients suddenly get a flu-like syndrome with abdominal pain, nausea, vomiting, then suddenly shortness of breath, the adult respiratory distress syndrome, cardiovascular collapse, and death. And so far, 70% of the cases, about 40 so far described, are fatal. And these are young, healthy people who have no underlying illness that start off with a flu-like illness, and in a week they're dead. The present therapy probably should be ribavirin, which is on the market for respiratory syncytial virus, but can be gotten especially for this disease because it's been active against other hantaviruses, although it's not been proven to be effective. And the reason that I even bothered to mention it in a lecture in Arlington, Virginia, is that the cases now are popping up all over the country. Viruses related to this and maybe actually identical to this have been isolated in Baltimore. And the concept is that this is a disease that does exist and will be, whoops, did I do something wrong? And we'll be seeing more of. So as of August, there were 30 confirmed cases. Now we're up to about 40. As I said, about 2/3 die. Most of them were in the Four Corner states, and now they're scattered around the country, and there's some just recent ones in the Northwest. Some cases were out of range of the deer mouse, so therefore other mice are thought to be vectors. And Baltimore, if you do serologic studies, you find that 3% of inner city people are affected. And it's very interesting. We've known for a long time that blacks have a higher incidence of hypertension than whites, and various explanations have been given. A new potential explanation is the fact that infection with this virus causes renal insufficiency and hypertension. And we may be surprised, as we were with some other diseases, that a disease we thought had a social cause or a dietary cause or a genetic cause may actually have an infectious cause. So again, we don't know the answer to that, but it's a very fascinating hypothesis that subclinical infections may result in hypertension, which may be clinically significant. The diagnosis is very difficult. You have to do serology, look for IgM, PCRs, immunohistochemical stains, and then there's one questionable report of a positive culture. The organism is not definitively identified, so we don't know exactly what hantavirus it is. This gives you an idea of a report in the Journal of Infectious Diseases in 1991 where they looked at hundreds of thousands of cases in China of hemorrhagic fever caused by hantavirus, and this is the mortality. You see, without treatment goes about 10 to 12%. With treatment, it's 2 or 3 or 4%. So this is the data. This is the entire data for recommending ribavirin be used for this infection. Another big outbreak, tuberculosis. This is very evident to us working at the University of Virginia because we've seen more tuberculosis this year than we have in the past decade. Complicated, resistant tuberculosis of all sorts of organs. The last case was almost a happy case because it was a woman of about 40 who was diagnosed as having metastatic ovarian carcinomas after sonogram and CAT scan because she had ovarian masses and peritoneal implants and surgery. They opened her up and said, obviously metastatic ovarian cancer. Took some biopsies, closed her up, and it was tuberculosis. So that's a happy diagnosis of tuberculosis. We can cure her. Virginia has the largest increase in the country in tuberculosis in 1992. We have a 20% increase. This is the predicted line of TB drops, and this is what's actually happened. So not only have we lost the predicted drop, but we're actually seeing an increase now. So there's no question that tuberculosis is making a comeback, and this is the time, of course, when doctors don't know a lot about it and TB sands have closed. The big problem, of course, is with resistant tuberculosis. And you see, when you compare 1975 with 1993, INH resistance now has gone from 4 to 10%. Rifampin resistance, which was almost 0, is up to 8%. Ethambutol, PZA, significant, and streptomycin. So we have a very high percentage of starting resistance to these drugs and have big problems. Now, this slide I know is hard to read, but it points out the association of multi-drug resistant TB and AIDS. And 2 points I want to make on the slide is, one, they are localized to New York City and Miami, and 2, the mortality ranges from 72 to 89%. And the mean weeks from diagnosis to death is weeks, 4 weeks in most of the cases. So a very virulent association of TB and AIDS, which is worrying public health officials tremendously. If you go to the big cities, and Washington, of course, is a big city, and you see the homeless shelters, realizing that a large percentage of the homeless, or significant percentage of homeless patients are HIV infected, a significant percentage are TB infected, you realize that we have a real formula for disaster, and we're seeing it. Now, I wanted to go through some of this, especially for those who are practicing medicine, because the guidelines have changed about who screening is recommended for. So we'll go through this in a little bit of detail. high-risk groups in whom screening for TB is recommended: persons infected with HIV, patients with risk factors for HIV if serologic status is unknown, close contacts of persons known or suspected to have TB, patients with abnormal chest x-rays, persons with medical risk factors, and then they list them. And the risk factors are silicosis, gastrectomy, jejunal bypass, very underweight people, patients with chronic renal disease, diabetes, on corticosteroids or other immunosuppressives, and hematologic disorders such as lymphomas and other malignancies. So all these people need to be screened for TB, even if there's no other clue for TB. In addition, foreign-born persons from countries with high TB prevalence, medically underserved, low-income populations, blacks, Hispanics, Native Americans, migrant workers, homeless, alcoholics, IV drug abusers, and then long-term facilities where TB is high, including correctional institutions, mental institutions, shelters, nursing homes, and other long-term residential facilities. You probably read recently about the outbreaks of TB on airplanes, where 20 to 30% of a 747 converted their skin test to positive, and they found the index case. And obviously this makes a lot of people pretty nervous about air circulation in airplanes. Now, the highest risk group should receive chemoprophylaxis regardless of the TB skin test status. So that means it doesn't matter if they're PPD negative or positive, you give them prophylaxis. And they are HIV-infected people who are likely to be infected. So that includes close contacts, those with previously untreated positive skin tests. So if they had a skin test in the past and they come down with AIDS, they should be treated for TB. Those with chest x-ray suggestive of previously untreated TB. Young children who are close contacts, and persons with a history of inadequately treated tuberculosis. We've run into a number of these people who've come in the hospital with active TB. So you see an old person, 75, 80 years old, and says, "Doc, but I was in the 1940s or 50s, I was in a TB stand and everything was fine. I didn't get treated then because they didn't have good treatment, and I'm doing okay." A lot of people say those people should be treated if they've never been treated before because their risk of coming down with active TB is significant. Now, this is the next group. The first was the highest risk group. You treat them no matter what. The second group is the high risk group. This group should receive chemoprophylaxis if the TB skin test is 5 millimeters. Now, you notice this is a change. When most of us went to medical school, we were taught that 10 millimeters was positive, under that was negative, and that was it. Now, we adjust the skin test depending on the patient. So some patients get treated with negative skin tests. That was the first group. This group gets treated with 5 millimeters. So anybody with HIV infection who has 5 millimeters is bought treatment for TB. Close contacts of infectious tuberculous patients, patients in whom chest x-ray shows parenchymal lesions suggestive of previous untreated TB. Just 5 millimeters is enough to indicate treatment. Then the last group is the moderate risk group, and here we've changed the criteria to 15 millimeters, or 10, depending on which group. The first group is persons with recent TB infection manifested by an increase in tuberculin skin test size, in other words, the converters. In persons younger than 35 years, an increase of 10 is significant. Older than 35, we talk about 15. And then those with a positive PPD, 10 millimeters, with any coexistent medical condition that predisposes. And that's where we get into the IV drug abuse, renal disease, diabetes, silicosis, malnutrition, etc. Duration of chemoprophylaxis, at least 6 months, 9 to 12 may be better. And I won't go into the details here, but this is all changing quickly. You see this references from the September 93 Annals of Internal Medicine. Now again, I know you can't read this from back there, but there's another major change, and I'll just point out the major change. This is from the CDC just a few months ago. The major change is that everybody with TB is treated initially with 4 drugs unless you're sure they're in an area where there's no resistance. So in the past, we were using 2 drugs and sometimes 3 drugs. Now the idea is to use INH, rifampin, PZA, and ethambutol or streptomycin. So you start with 4 drugs unless you're sure you're in an area where there's no resistance, and that certainly doesn't hold for Arlington or Washington, D.C. So if you see a patient with TB, you follow the CDC guidelines, you start with 4, and then you can cut back if you find that the organism is sensitive. The other thing that's new is this DOT, directly observed therapy. So many of the patients get into trouble because they don't take their drugs that there's a whole system now built in where patients can have their therapy observed. And of course, the reason is that there are no more SANs. In the old days, if we had somebody who wasn't an optimal citizen, we'd send them to a TB SAN for a year or 2, and every morning somebody would come by and give them their drug. Now, we don't have any more TB SANs, so you take a homeless patient and you give him a bottle of pills, and whether he takes it or not is always a problem. So the idea is that you use this DOT, directly observed therapy, where they come in to a clinic a couple of times a week, and they get larger doses a couple of times a week. And of course, if they don't come in, then somebody has to go out and find them. Here's a case which represents another, quote, new disease. And this is a patient that we saw at the university, and we've seen a number like this. This man was perfectly healthy. He developed a cellulitis with bullae, necrotizing fasciitis, shock, and renal failure. Anybody have any ideas what you worry about with him? Strep is right. He has severe streptococcal infection associated with scarlet fever, and this has really come back or appeared, and it wasn't with us for a few years ago. It's associated with certain toxins. 60% of the patients have positive blood cultures. Soft tissue is the most common site. Initially, patients were seen in the Rocky Mountain area, the Middle Atlantic states. Now they're seen all over the country. Renal failure and toxic shock-like picture is seen. Often you need surgery to cure them and antibiotics, and the mortality is still high. Remember, this is what Jim Henson died from. His disease was not soft tissue, it was pneumonia. He had a group A streptococcal pneumonia with toxic shock syndrome symptoms and signs because of the toxin-producing organism. So the summary of this is that all ages, predominantly adults, either sex, usually skin or soft tissue, but you can also see it in the respiratory tract, as in the Henson case, the vagina. Clinical features: fever, hypotension, altered mental status, coma, rash, often a localized cellulitis with vesiculation or bullae, generalized erythroderma with desquamation, and then multi-organ dysfunction, especially ARDS, renal, liver, and heart failure. And the case fatality rate described here is about 30%. The new exciting basic science connection here, which has implications for many diseases, is the concept of a super antigen. Turns out that many bacterial toxins, or at least a few bacterial toxins, can function as super antigens. Normally, when an antigen-presenting cell, such as a macrophage, activates a T cell, it does it through the T cell receptor combining with the antigen and then presenting this, this is the MHC2 molecule, this is the T cell receptor, presenting the antigen to the T cell receptor. The T cell receptor recognizes the antigen. This triggers the activity, and the body responds. It produces cytokines, etc. What the superantigen does is that in the absence of an immune T cell, this superantigen is so potent it can activate T cells without the T cell seeing a specific antigen. So instead of activating just a small subclone of T cells that are especially designed to interact with this antigen, the superantigen massively activates T cells, and you get the body turning on an inflammatory situation where you have things like toxic shock related to this. It's thought also that there are a number of other diseases related to superantigens, and I've listed some of them here. Staphylococcal toxic shock, food poisoning due to some staphylococcal enterotoxins. Group A, pyrogenic toxin, does the toxic shock-like syndrome we're talking about now. And also a disease like Kawasaki disease is now thought probably related to staphylococcal superantigens. Kawasaki's disease, as you know, is a disease of unknown etiology, especially seen in kids where they have strange lesions such as coronary artery aneurysms. And this now is thought to be a superantigen disease due to bacterial toxins. Well, here's another disease that you've seen, and a disease that we worry a lot about. In fact, one of the jokes in Charlottesville is one of our major clinics probably should be the Fear of Lyme Clinic, because it's caught on, especially the upper middle class population is very concerned about Lyme disease and is very afraid of it. But this is an indication of a capsule presentation of a patient with Lyme disease. And Long Island, as you know, is a hotbed, as is Connecticut. We see Lyme disease in Virginia, but we're not nearly as high an incidence place as places in the Northeast. And as you know, this is a characteristic presentation with a skin lesion, arthritis, and even some heart involvement with AV block. The life cycle of Lyme disease, of course, starts with an egg hatching and then a tick, and the tick gets infected by biting hosts such as mice, and then once it carries the organism, then can bite secondary hosts such as people. And this cycle goes on, and it turns out that the vectors vary in different parts of the country, and as people like to do, they keep changing the names of the vectors of Lyme disease. We know the causative organisms. The causative organism is Borrelia burgdorferi. It's a spirochete. The vector are small, hard ticks. We used to call them Ixodes damoni. The new term now is Ixodes scapularis, parenthesis damoni, because scapularis was a name that preceded damoni. But the point is that they're small ticks. They're much smaller than the common dog tick that we see most often in Virginia. They're frequently described the size of poppy seeds, and I don't know how many people see poppy seeds, or at least know that they are. My wife had to show me what a poppy seed looked like, but poppy seeds are very small, and they come on rolls, so I don't know where else they grow. So Lyme disease is seen in the spring, summer, and early fall in the north, and it's seen all over the country. And if you go around Lyme, Connecticut, and get blood from everybody, about 4% of people are positive. And it's very interesting that only a small percentage of those will have a history of illness. So like most illnesses, there's probably a lot of asymptomatic Lyme disease. This is an interesting graph, because this graphic, because what this shows is the incidence of Lyme disease around the country, number of cases, and you see New York had 1,000 and Virginia had 113, so about a tenfold difference in number of cases. And then hot spots up here. Excuse me, New York had 7,000. I was looking at Pennsylvania. New York had 7,000, so 70 times as much as Virginia. But look at Georgia, 700 cases as compared to 34 in South Carolina and 28 in, what's this, Alabama, something like that. 7 in Florida. So you see that, now, that's really fascinating, and without going through a lot of stuff, it was a lab error. There's a mistake. The laboratory was misdiagnosing Lyme disease, and Georgia doesn't really have a lot of cases. And so the problem with Lyme disease is, how do you make the diagnosis? And it's very difficult. These are some pictures of the tick that appeared in the New England Journal, and you see one attaching here and all the approved ways of pulling them off and stuff like that. And again, the nymphs can be very, very tiny and hard to find. These are actually ticks off my own kids from Charlottesville. And these, of course, are dog ticks, the Dermacenta variabilis, but even the babies here can be very, very tiny, and this is a dime. Now, these do not transmit Lyme disease. They transmit Rocky Mountain spotted fever. Here's a good example of a Lyme tick and a pinhead, so they're very, very tiny, and you can see they can get amazingly tiny. After you're bitten by a tick, you have a 3 to 30-day period of incubation. Often you're asymptomatic, but you're going to have a flu-like illness, and then you get this characteristic rash, the erythema migrans or erythema chronica migrans. 50% of patients that have the rash, which is thought to be about 60 to 80% of all patients infected, 50% will have a single lesion, and then 50% will have multiple lesions. Then they have malaise, fever, lymphadenopathy, splenomegaly, stiff neck, and pharyngitis, all may be seen. And this is a classic rash of erythema chronica migrans or erythema migrans. And the idea is that it's a target-shaped lesion, more red in the center. This reminds me of a case we saw in Charlottesville where a young woman came into the clinic with a red lesion with a scar and some sutures in the middle. And I said, tell me about that. She said, well, I got bitten by this tick, and I've been doing some reading, and I think I have Lyme disease, but my physician doesn't really agree. I said, what do you mean your physician? She said, well, I have to confess, I'm married to a surgical resident, and when he saw the first thing, he cut it out. And I'm afraid now that it's bigger, I don't want to let him see it again because I don't want him to cut out the rest of it. And I think so she had Lyme disease, but you can understand what happened initially. She had a tick bite, an erythema around the tick bite, and he thought that there was some remain tick parts in there, and he thought that by doing that he would cure the disease, which then became obvious as the lesions increased. And here's another picture of the same kind of lesion. The next stage you get, which can be weeks to months, you get arthritis, which can be destructive. You can get aseptic lymphocytic meningitis, encephalitis, Bell's palsy, especially bilateral, and then some can get fluctuating AV block, myocarditis, and there's been reports of fetal damage. Treatment, again, I won't go through the details. Treatment is very effective in proven cases. Treatment doesn't work very well when you don't have Lyme disease. And that's the major problem with Lyme disease today, is that many patients who are thought to have Lyme disease don't have it. And again, I won't go through these details with you now. Now, the reason that where this comes up relates to the incidence of the disease and some boring statistics and the sensitivity and specificity of the Lyme test. Annual incidence has been estimated as follows. You see the Middle Atlantic states very high, and then South Atlantic maybe a tenth as much or less, and then very low in certain states. So you see it depends on where you live, and even the highest is 6 per 100,000. The reason this is important, because if you look at a disease, I say disease in quotes, but the rheumatologist recognizes a disease called fatigue myalgia syndrome, where patients are fatigued and have aches and pains. This is thought to occur in this amazingly high proportion of 2,000 to 5,000 cases per 100,000. Remember, the highest was 6 of Lyme disease. So if you do Lyme serology, you're going to mess up. And what happens, and this was just reported in the Annals, actually, as a joint report by the American College of Rheumatology and the Infectious Disease Society. Even if the Lyme disease test is 100% sensitive and 98% specific, then even in the highest Lyme area, Lyme, Connecticut, for those with positive serologies, there'd be 167 non-Lyme disease fatigue myalgia patients for each Lyme disease. In the mountain states, it would be 50,000 to 1. In Virginia, it would be a few thousand to 1. So what I'm saying is that if you have a patient that comes in and says, Doc, I have fever and myalgia and fatigue, and what kind of fever? Well, 98.9 or 99.2, and I've been out in the woods, get a Lyme titer on me and see what it is, and you get a Lyme titer. The odds are hundreds to thousands to 1 that Lyme titer doesn't mean Lyme disease. And so those patients get treated and they don't respond. So we're stuck with an imperfect test, and many of these people don't respond, and many of them go from physician to physician getting more and more treatment. And if you're interested in this, look in the most recent or maybe last month's Annals of Internal Medicine, where it's spelled out in great detail. Seronegative Lyme disease is very uncommon, especially with arthritis. The only cases that have really been recognized are those that gotten treated very early. even those cases will respond to 30 days of oral therapy or 2 weeks of IV therapy. There's a very rare subgroup that may not respond, and these are chronic arthritis patients, not arthralgias, but arthritis, and some of them may require therapy. Now, I'm showing you this, not because I want you to run out and do it, but this is an exciting development. This was in the Journal of Infectious Disease this month, and it's a laboratory study by an expert, Andy Spielman and his colleagues up at Harvard School of Public Health have been studying Lyme for a long time. And what they showed is that if you allow a tick to bite a mouse and then put antibiotic cream on the tick, you will prevent Lyme disease. Other studies have shown that oral antibiotics are either ineffective or the incidence of disease is so low after an infected tick bite that it's not recommended. Something like this clearly is ready for study because it would be very nice to be able to tell patients if you get a tick bite, put this cream on and you don't have to take oral drugs to, quote, prevent Lyme disease. But we don't know if that's going to work in people. Another disease I wanted to talk about is a new infection. I've been told we have to quit at 9 o'clock. So we'll make this the last of the diseases. But this is a disease that you all know about. And I think if any of the wise physicians in the audience a few years ago were to make a list of diseases of unknown cause that were caused by infectious agents, that they thought were caused by infectious agents, they would have listed rheumatoid arthritis, multiple sclerosis, ulcerative colitis, regional enteritis, and I'm sure you can come up with a few others, but nobody would have listed this disease, which of course is peptic ulcer and gastritis, and you all know the story. And we're very proud in Charlottesville of the role that Barry Marshall played in this. Barry is a professor in our gastroenterology department, and Barry was written up many places. This is in Science, and wonderful, long, detailed write-up in this month's New Yorker magazine about Barry's adventures. And the story basically is that Barry was a GI fellow in Australia and working with a pathologist who noted that there were curved bacteria seen in the stomachs of some patients with ulcer. And the dogma was, of course, that the stomach gastric acidity killed bacteria and the stomach was sterile, but they saw these things. So Barry worked on culturing them, finally cultured them, identified them, and found this association, and after a lot of conjecture, decided that the way to answer the question was to drink it. So he grew up a glass of culture material, drank it, had his friends scope him before he drank it, had a normal stomach, then he developed gastritis, then he took antibiotics, got better, and then he was convinced, and the rest is really history because studies all around the country have shown that gastrointestinal disease associated with H. pylori is very important. The definite association, and now we can say more than association, is gastritis, recurrent duodenal ulcer, initial duodenal ulcer, clearly, strongly associated with gastric ulcer and gastric cancer. Non-ulcer dyspepsia and chronic alcohol-associated gastritis, and not associated with some other things, showing that most likely it's not secondary. Again, let me just move on to some quick things which you've seen. This is percent with ulcer recurrence. This is from the Annals of Internal Medicine, 1992. This is patients treated with ranitidine. 100% recurred after a while. Patients treated with antibiotics, less than 20% recurred. Same thing with gastric ulcer. I think we lost our focus. Same thing with gastric ulcer where the antacid, the H2 blocker, resulted in recurrence, and the antibiotics didn't. A very important study done in February of this year looked at amoxicillin and metronidazole without the bismuth in there, because some skeptics were saying, well, the bismuth used for this disease may do something special to the mucosa. So if it's really a bug, you should be able to cure it with just antibiotics. And that's what they did. They had amoxicillin and metronidazole versus placebo. Probability of remaining in remission, you see almost 100% here. in placebo down to nothing. So the answer is that this is very important and causes disease. This is actually a symptom score in alcoholics with gastritis and treatment for H. pylori. This is the placebo and this is the treatment. Well, there are lots of other diseases I can talk about. Let me see if I can race right to the end here because time is short. And, whoops, one more. And just show you the final slide, which indicates the successes we've had. And we hope in the next year or two to add polio to this. It's possible, certainly in the Americas, that polio will be eradicated. So these are our successes, and these are the so-called new diseases. And of course, this slide's a couple of years old, so we'll go right up to the ceiling. So those of us who practice infectious diseases, I don't think have to worry about being put out of work in the near future. I thank you for your attention.
A few questions? Sure. We have a few moments for questions. I have a question for you.
Sure.
In those populations which have a higher gastric carcinoma incidence, is there a higher incidence of H. pylori?
Yeah, I didn't show you those figures. The problem with a lot of these studies, of course, they're associations. And it's sort of like smoking. Not everybody that smokes gets lung cancer. And not everybody with lung cancer smokes. And I think you can say the same about H. pylori and gastric cancer. There are gastric cancers occurring in patients who you can't isolate H. pylori from. And there are lots of people with H. pylori who don't have gastric cancers. But the association is very close. And epidemiologic studies have been done mostly in other countries because the rate of gastric cancer in this country is decreasing. We don't know exactly why, but it's decreasing. But worldwide, it's thought to be an important candidate for a factor as factor or cofactor. But the association is very strong.
Bill?
Terry, what do you prophylax the healthcare worker who's been exposed to a
Yeah, excellent question. And luckily, we are not faced with that often in Charlottesville. But the question is, what do you prophylax a healthcare worker who's been exposed to resistant TB with? First fact is that we don't know because the only thing that's ever been shown to be effective in any prophylaxis is INH. So as soon as you move out of INH, you have no idea what's going to work. What we do is guess. When I say we, I really mean the places like New York where they see this a lot, and they guess, and they've made up things like ciprofloxacin and ethambutol. In other words, they take two drugs that you can give orally for 6 months and give it. Frequently, of course, what happens is, especially in a place like New York, you have somebody working on a ward where there are both resistant and sensitive patients, and when you do your yearly screening of a house officer, you find out somebody's converted their skin testing because you don't know if it's the resistant or the sensitive. So frequently they'll get INH also because of the hope that maybe it is a sensitive bug. The one piece of data that is of interest is that in India, when a family member has resistant tuberculosis, about 50% of the family contacts will come down with sensitive tuberculosis. So the feeling is that if you have resistant TB, the organisms you're coughing up are a mixture. Now, if you treat just those sensitive bugs, you're not going to get better because then the resistant ones take over. So you have to worry about both bugs. But we really don't know what to do. I was afraid you were going to ask the HIV question, which of course is the same thing. You know, what do you do if somebody's stuck with an HIV-positive needle and nobody knows what to do? A lot of places offer AZT, but nobody knows if it's beneficial, harmful, or neutral. Very good question, and the question is, because of the outbreak of TB, especially resistant TB, shouldn't BCG be offered? And that's being discussed at all levels, and the arguments go, one, the effectiveness of BCG is still in question except for certain studies. So it seems like some studies showed it worked, some studies didn't, and maybe it relates to batch. 2, despite the bad figures I showed you, we're still in a relatively low TB country, and the BCG does, at least for a short time, nullify the usefulness of the skin test. So people are talking about that a lot. And for example, if you were going to serve an internship at Montefiore Hospital in the Bronx in New York, and you knew that you were going to take care of 20 patients with resistant TB, which aren't the big problem. The big problem is the guy that comes in with a cough at night and you don't know what he has, and you're PBD negative, would you want to take BCG? And that question is being asked a lot, and we don't know the answer yet. I mean, I don't know what the decision is. It's certainly a reasonable question to ask, at least for certain selected segments of the population. There's no question that in some studies, BCG had a protective effect, but it's not 100% effective.
Any other questions? Yes.
In the old days, in some countries other than the United States, they used to have surveys of the population which probably was more exposed to tuberculosis, and they used to do what they call a photofluoroscopy, for a small X-rays of the lungs. Would this be applicable at this point?
Well, the concept is that the PPD is so good in a country like this where the yield, where the positivity is still very low. In other words, the percent positivity in the population is still just a few percent. We test our medical students every year, and we're talking about 2, 3, 4%. Obviously, it's a certain socioeconomic group that goes to medical school. But young people still are most often PPD negative. So the thought is that the TB skin test is still a better screen than a chest x-ray, more economical and no risk as far as radiation. If you have an area where you have a lot of people positive, then the idea of chest screening, and many of us can remember the vans, even in the States, pulling up, and people would line up and get routine chest x-rays. People were always using that as a screening test. But the skin test now has gotten to be more effective as TB has gotten less common. Now, it may change if that curve changes a lot.
Yes.
One of the slides that you went through for about a tenth of a second there at the end talked about how to resist the parasite. For the ones that you're seeing, you're resistant to vancomycin, to everything. What do you do?
Well, let me just expand on the question just to tell the people what's happening, and that we're seeing many important resistant organisms, especially the pneumococcus, which never was resistant before, to penicillin, which is a major problem. And we just heard about a case last hour of a woman who came in with resistant pneumococcal infection. That's going to change medicine. Now we have the enterococcus resistant to all kinds of antibiotics and just about everything. And one answer is that there's no treatment for them, and that's it. You know, it's like cancer. It's just, sorry, you have it, we can't treat it. And that's tough for infectious disease people to say, so we're always trying something. And there's usually something in vitro that you can come up with, things that there's no clinical proof that works, such as ampicillin, sulbactam. You know, I mean, you're shaking your head. Appropriately, no, because the real answer is we don't have anything good for it, and that's the crisis that we're running into. So occasionally we run into those organisms, and it's very hard for us to get used to that here's a plain old bacteria that we have no treatment for, and that's happening. So we hope the companies are going to develop things and get ahead of the bug again, but right now we're getting behind in certain organisms.
One more question? Yes.
How often would patients with chronic medical conditions be screened for TB?
Yeah, that's a good question. I think we obviously don't know the answer. I can't give you, certainly once would be an easy answer, that if somebody's in your practice, in your clinic, in your hospital, and they haven't had a skin test in a long time, I think they should have a PPD. then I think you have to sort of play it by ear. In the hospital, as you know, it's most hospitals, certainly our hospital, is standard for all people with health, with patient contact to get skin tested yearly. It may be a little bit of an overkill with somebody with no contact. If somebody lives a good, stable home life and there's nobody around who has TB and they're not out in the workforce or something, probably reasonable to do a one-time shot. On the other hand, if somebody's working as a volunteer in a homeless shelter, then I think that person should be tested every year. So I think I'd play it by ear.
Well, thank you very much. I appreciate that. Mr. Dolan? Please stay up for a minute.
Thank you very much for an outstanding presentation. It's in keeping with the previous speakers that we've had here. Now, as a staff, medical staff, under this fancy thing is a plaque. I don't know just why they did this, but instead of having there's a plaque here which we hope you'll take and keep in your office and reminds you of this visit and stimulate you to come back.
Thank you very much. Appreciate it.
I'd like to add my thanks to Terry Mandel for a wonderful presentation. I can't help but have a personal remark. Listening about the rise again of tuberculosis, I served as chairman of the Board of Health in Virginia back in the early 70s, and we were closing all the sanitaria like this. How fragile life is in the universe with bugs, that we think we've got it licked today, and 10 years from now it comes back. And we thank the Lord that there are people like you who are working on our behalf. And we now have a reception, and everyone is welcome to come in and mingle. And I thank you again for coming, and we look forward to you all being here next year for another Joe DiMaggio. Thank you very much.